Good morning all. Today we are going to discuss one topic, ABG. Okay. So starting with one clinical scenario, 50-year-old gentleman with abdomen pain, increased urine output, lethargy, sodium 135, chloride 110 and blood sugar 600 milligram. And the ABG values are like this, and bottom line there is FiO2. So as we get an ABG, it's more important to know the clinical condition of the patient. That's why I have given the clinical scenario. So when you approach an ABG, you have to think about the clinical scenario and what is the patient condition is. Then you have to approach the ABG. Then only you have to interpret the ABG. That's why I put a slide like this. So the same thing. If you want to know about perform an ABG and analyze the ABG, you should know the history of the patient initially, and you should have a physical finding, examination finding. Then we have a non-invasive method of measuring the saturation. What is it? It is pulse oximetry. So even if we having this much facilities, we are going to an invasive procedure. ABG is an invasive technique, right? So we have to have a clinical correlation with all these parameters. So what are the indications for doing an ABG? So mainly we have to establish the cause of an oxygenation abnormality, right? If a patient presenting with a severe hypoxia, so you are in a doubt what could be the cause of the hypoxia, then that is an indication for doing an ABG. To evaluate somebody's hyper or hypoventilation and to know the patient's acid-base status. Most of the time we only look for the acid-base status, but the main thing are oxygenation status also. So you have to look at the oxygenation status also. So it's the track application for mechanical ventilation in a critical ill patient. So even though these are the indications, most of the time we don't need ABG to analyze the patient condition, even the patient is in dyspneic or whatever condition, because if a condition it's already established. If a patient of a known case of bronchial asthma coming with a exacerbation, we know this patient is having a bronchial asthma exacerbation. To diagnose, I don't need an ABG, right? So it's not a good practice that all the dyspneic patients has to be evaluated with ABG. So if a patient, when the cause of dyspnea is suspected and the patient is not especially ill, somebody is having dyspnea but he is not that much ill, that is again not an indication for doing an ABG. So there are limitations for ABG also. Even if you are doing ABG, you are looking at the oxygenation by looking at the PaO2. So PaO2 not a definite sign of oxygenation for all patients. Example, one patient is severely anemic. His hemoglobin is significantly low. Hemoglobin carries the oxygen most of the time, right? So plasma will carry nearly very few amount of oxygen. So mainly ABG counts for the oxygenation from the plasma. So it is not an ideal, always not an ideal measure to think about the oxygenation. And definitely we do ABG through the arteries. So they hurts. It's a painful procedure. Ideally we have to give local anesthesia, under strict aseptic conditions you have to do. There is possibility of we can take samples from ABG veins also. So study says that there is no much difference between ABG and VBG if you are not really concerned about the oxygenation status of the patient. If you are thinking about the basic electrolyte abnormality or the acid-base status, VBG is more than enough. And finding an arterial plus is difficult in a hypertensive patient. Of course, we know the patient is sick, BP is very low, then it is very difficult to palpate the artery and do the. And there are definitely, if it is an invasive procedure, we do directly pricking at the artery, so there will be complications such as arterial thrombosis, everything is possible. So if you get an ABG, what are the things you look at? The PaO2, that is oxygenation, PCO2, pH, some electrolytes, lactates, bicarbonate, saturation, and some other calculator also. So we are coming to the organized approach of the ABG, how to interpret the oxygen. I told you, most of the time when we get an oxygen, we directly look up at the bicarbonate, pH and all. So it's not an ideal way. If the PaO2 is also very important. Oxygenation status of the patient is also important if you are clinically suspecting some oxygenation abnormality. So what is a normal PaO2? Normal PaO2 is normally between 95 to 105, but it's pretty age dependent also. An elderly man can have a low PaO2 also. So don't think that everybody is having a PaO2 of 105. So if you get an ABG initially, first thing you have to do is you have to validate the ABG. How you validate the ABG? You will be getting a PCO2 value in the ABG, right? So you put it apply it in the formula 24 into PCO2 by bicarbonate, then you get the value of H plus. That H plus, you will have a chart like this. You keep the chart like this, you can download it from the net. And if you get a value of H plus of 40, means it should be corresponding to a pH of 7.4. So you have to look at the ABG. Is it showing the 7.4 ABG, 7.4 in the ABG? If that means, if it is there, means it is validated. That ABG is valid. So if you are getting a PCO H plus of 79 after applying in this formula, then it should be pH should be 7.1. So you have to look at the ABG. So 7.1 is the pH. If it is 7.1 means it is the ABG is validated. So an example, ABG pH of 7.5, PCO2 30, PO2 105, bicarbonate 22, saturation of 98, PO2 A minus A. What is that? It is the alveolar arterial gradient. So it is 8. So what is that? It is again a method to diagnose certain conditions in an ABG, with an ABG. So if a patient having a gradient low means there is some significance, and if it is normal means it is having some significance. If a patient presents to you with a breathing difficulty, a dyspneic patients. So if a patient's PaO2, if you are getting an FiO2, that is you are giving how much oxygen you are giving. Like if you are giving with a nasal prongs, this much liter means this much FiO2. So you can calculate PaO2 by if you know the FiO2, and all the rest of the things are constant. PCO2 is again you will get from the ABG. So you apply in that, you will get an PaO2, which is alveolar oxygen amount of alveolar oxygen. So if you calculate the PaO2 and you minus it from the PaO2, which is the arterial oxygen, then you will get lot of DDs like this. So that is again an application of ABG. You calculate the AA gradient, and your diagnosis can be, or your differential diagnosis can be narrowed down to certain diseases, and you can work up upon it. So example, if a patient presents you with PCO2 is increased means what? The patient carbon dioxide is retaining in the body. So there is carbon dioxide retention, means there is hypoventilation. Patient is not breathing properly maybe. So how you differentiate? By looking at the PaO2. PaO2 ratio is increased means there is gradient is increased means then there will be hypoventilation plus another mechanism which is causing a problem in the diffusion of oxygen from the alveoli to the arteries. So if it is normal means PaO2 ratio is not increasing means it is only hypoventilation. Patient is not having adequate respiratory drive. That could be the cause of hypoventilation of this patient. I just give that slide to show the other applications of ABG and how you narrow down your diagnosis. So coming to the actual ABG approach. So we know there are some acid-base abnormalities, especially respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. These are the things we mainly look upon at the ABG, right? Acid to diagnose the acid-base balance. So there is a 6-step approach how to diagnose an acid-base balance. The first thing you have to check whether it is the ABG is acidic, the blood is acidic or alkalemic. Is the primary disturbance is respiratory or metabolic? That is the second step. And third step is if it is respiratory, it is acute or chronic. And if it is metabolic, is there any anion gap? And are there any additional metabolic abnormality if there is a high anion gap metabolic acidosis? and assess the normal respiratory, all the compensation for the metabolic abnormality. So coming to the initial step, if a patient, you will get an ABG, you are getting an ABG means first step you have to look at the pH. Okay, if pH is acidic means next step you have to check at the PCO2. So you look at the PCO2 is more than 40 means it is the acidemia is because of the respiratory cause. Because if the carbon dioxide increases in our body, which combines with the water forming by HCO3 minus, right? That it is acidic. It will diffuse to it will degrade to H plus and HCO3 minus. So H plus is a strong ion. So if you are having increase in carbon dioxide means it is respiratory acidosis. So first step is pH. If it is acidic, you look at the PCO2. PCO2 high means that PCO2 is the cause of that acidosis. So PCO2 is the cause because that's why it is respiratory acidosis. Clear? So if it is less than 40 means it is metabolic acidosis, because that acidosis is not because of the carbon dioxide. The only option is bicarbonate. So bicarbonate decreasing, that is causing the acidosis. So it is metabolic acidosis. So the opposite, if the patient is the blood is alkalemic means what could be the cause? Then again you look at the PCO2. If more than 40 means that alkalosis is not due to the carbon dioxide, because always carbon dioxide causes acidosis. So carbon dioxide increases means this alkalosis is not due to the PCO2. So it is the alkalosis is from the metabolic side. So it is metabolic alkalosis. If the PCO2 is less than 40 means it is because of the carbon dioxide washing out. That's why it is causing the respiratory alkalosis. So two possibilities, even if it is a respiratory parameter, respiratory abnormality, it can be acute or chronic, because respiratory parameters is having this acute and chronic property. But if something is metabolic, it doesn't have an acute or chronic, it is only, you will say, metabolic alkalosis or metabolic acidosis. Because metabolic abnormalities are mainly because of, it is related to the kidney. So kidney acts very slowly. So that's why there is no acute respiratory metabolic acidosis or acute metabolic alkalosis. There is only metabolic acidosis or metabolic alkalosis. There is no acute or chronic. But our lungs compensate it very fast, and lungs acts very fast. So it is having an acute and chronic property. So that's why if a patient presents you with an acute respiratory disturbance, then you have to check for if it is an acute or chronic. So how you differentiate it is an acute and chronic? You have a PCO2 value, you minus it by the normal value, which is 40, and divide by 10 and multiply by 0.02. Means if a patient is having an acute respiratory acidosis, there will be having a change of 0.08 into the change of into the change of PCO2 from the pH. I'll give you an example, then you understand. In the chronic case, the change will be 0.03. Means chronic pH will not change that much, right? It is a chronic process. So the kidney having time to compensate with the alkalosis. So as alkalosis or acidosis. So it will take more. It is getting more time. So the pH will be more towards the normal side. There will be less change with the change from the pH amount. So that is only the fraction amount is 0.03 into the change in bicarbonate the change in PCO2 divided by 10. So, and then you recognize that this is a acute or chronic cause. Then the next step, if it is a metabolic acidosis doesn't have an acute or chronic. If you find out this is a metabolic acidosis, then next step is to check the anion gap. Anion gap is the change, the difference between sodium minus the chloride or plus bicarbonate, positive minus the amount of negative ions. Usually it is 10 to 12 is the normal value, and if you say the patient is having a metabolic acidosis with an anion gap more than 12 means it is a high anion gap metabolic acidosis. If less than 12 means it is normal anion gap metabolic acidosis. So if a patient presents you with acidosis, metabolic acidosis means bicarbonate is low and the anion gap is high, means it is high anion gap metabolic acidosis. So what could be the cause of high anion gap metabolic acidosis? So these are the main causes of high anion gap metabolic acidosis. Shortly we say HAGMA, high anion gap metabolic acidosis. So how you say, then you can narrow down your differential diagnosis into this mnemonic mud piles, methanoluremia, DK, paraldehyde, infection, lactic acids, ethylene glycol and salicylates. So coming to the non-anion gap metabolic acidosis means the anion gap is normal, means the bicarbonate is reduced. It's because of there is loss in bicarbonate. That is why it is normal anion gap metabolic acidosis. The other scenario, bicarbonate is decreasing because something else is increasing. That something else is mud piles. But for non-anion gap metabolic acidosis, the bicarbonate is reducing because the bicarbonate is itself losing from the body. So what could be the cause of bicarbonate loss? It can be diarrhea, renal losses, renal tubular acidosis, carbonic anhydrase inhibitors or ureteral conversion. So you will diagnose that it's a metabolic acidosis. It's not the stopping. Again you have to check is there is another metabolic disturbance coexisting with the anion gap metabolic acidosis. How you calculate it? For that you have to calculate a corrected bicarbonate. How you calculate the corrected bicarbonate? Corrected bicarbonate is the bicarbonate plus the anion gap minus 12. So I will give you an example. So the corrected bicarbonate more than 26 means there is an additional metabolic alkalosis. Less than 22 means there is a non-anion gap metabolic acidosis. I will give you an example. So coming to this, anion gap metabolic acidosis. You know bicarbonate is 10 and anion gap is 26. Consider pH is less than 7.4. So it is metabolic acidosis, no doubt, right? pH is less than 7.4, that means it is acidosis. And you look at the bicarbonate is low here. So it is a metabolic acidosis. I didn't give the value of PCO2. Consider PCO2 is compensated according to the value. So anion gap is 26. So anion gap normally is 12. So it is 26 here. So anion gap, it is a high anion gap metabolic acidosis. For each of the step, it is a high anion gap metabolic acidosis. Then the next step is is any additional metabolic abnormality is there with the high anion gap metabolic acidosis. For that you have to calculate the delta H. So how you calculate the corrected HCO3 minus? For that you apply the formula which I showed. Means the bicarbonate is 10 here, right? 10. And the anion gap is 26. Normal anion gap is 12. So 26 minus 12 is 14 plus 10. So the corrected HCO3 is 24. That is a normal bicarbonate value, 24. So there is no additional disturbance. There is only high anion gap metabolic acidosis. Okay. Now coming to the second case, the bicarbonate is 15 here and anion gap is 26. So definitely again a high anion gap metabolic acidosis. Coming to the next step, calculate the bicarbonate, corrected bicarbonate. What will be the corrected bicarbonate? It will be 15 plus 26 minus 12, right? So it is 15 plus 14, which is 29. So it is 24 is normal, but here is 29. So there is an additional bicarbonate in the blood. That means that there is an additional metabolic alkalosis is there, right? That is why we calculate the corrected bicarbonate and check for any additional metabolic abnormalities there or not. So there is an additional easy method how to diagnose this additional metabolic abnormalities is there. Normally we can calculate a delta anion gap also. Delta anion gap means the anion gap which is calculated by the sodium minus chloride plus bicarbonate, and you minus it from the normal thing. Normally is 12, right? So if a patient is having 25 anion gap, the delta is 25 minus 12, which is 13. Okay. So delta HCO3 minus the actual bicarbonate patient has and minus with the normal 24 if it is 15, 24 minus 15. So you will get a delta bicarb and you apply it in the formula. According to this formula, if it is 1 to 2 indicates there is only metabolic acidosis, but if it is less than 1 means there is an there is an additional non-anion gap metabolic acidosis is there, and if it is more than 2 means there is a concurrent metabolic alkalosis. It's a simple step, another method to calculate any or diagnose any additional metabolic parameters is there. And additionally, you have to think about other factors also which can influence the acid-base balance. One of the things is albumin. If albumin decreases means anion gap decreases. So if somebody is having an albumin of 2 means their normal anion gap is 7. So how you calculate the anion gap? You have to use this formula, means you have to calculate, you have to minus the normal value is 4, right? Albumin normal value considered to be 4, and the patient has albumin is 2 means 4 minus 2 which is 2 into 2.5 which is 5, right? And you have to calculate, add with the actual anion gap which is getting from the formula. So if the patient's formula is 7 means 7 by plus 12, that is a normal anion gap. So you have to calculate, you have to think about albumin also while calculating anion gap, that is the corrected anion gap. So coming to the last step, if you are getting a metabolic parameters or whatever abnormality, then you have to find out what could be the compensation because of that the primary acid-base balance. If somebody is having a metabolic acidosis, of course the patient is having acidosis, what body will say? Body will try to compensate that pH, compensate that acidosis by there will be an additional or compensatory alkalosis against it, which will be the respiratory alkalosis. Metabolic acidosis compensation will be because of the respiratory alkalosis. How you compensate, how the body compensate, this is easily calculated by this formula. So if a patient having a metabolic acidosis, you have to calculate the PCO2. How you calculate? Consider if a patient's bicarbonate is 15, you apply this in the formula. 15 into 1.5, that will be 22.5, right? 15 into 1.5, which is 22.5 plus 8, it will be 30, nearly 30. So if you look at the ABG, the patient's PCO2 should be 30. That is the actual compensation, right? If it is not compensating means there is additional, some problem will be there. Okay, this is how you calculate. Coming to the metabolic alkalosis, the PCO2 bicarbonate is considered 10, then 0.6 into 10 means 6. 40 plus 6, that is 46. The patient's PCO2 should be 46 while checking at the ABG. Consider if you are expecting a PCO2 of 46 and you are seeing a 40, means there is an additional respiratory alkalosis there, which is causing that carbon dioxide washout. So the same compensation for acute respiratory acidosis is also there. You can calculate by this formula. Increase in bicarbonate is equal to change in PCO2 by 10. Chronic respiratory acidosis, respiratory is having acute and chronic. So that's why acidosis and chronic, there will be a chronic acidosis, respiratory acidosis and respiratory alkalosis, there is an acute and chronic component. The compensation is little different. Okay. So this is how you calculate the compensation also. So you can apply this to any clinical scenario, apply this formula, you can get what could be the compensations and you can correlate clinically. So we are coming to one example. If a patient, clinical case is a 5-month-old baby with bronchiolitis. His pH is 7.24, PCO2 40, PO2 59, bicarbonate 24, base excess of +4 and saturation of 85 and FiO2 70%. So initially looking at the parameters, so this is I told you earlier, before interpreting the ABG, you have to first look upon the patient's clinical condition and you have to have a DD, what could be the causes and what are the abnormalities you are expecting from the clinical condition of the patient. Then you have to approach the ABG. So the 5-month-old baby with bronchiolitis means you are expecting a respiratory problem because the patient is having bronchiolitis. And you look at the FiO2, you are giving a 50 FiO2 means oxygen saturation of nearly oxygen amount of nearly 70%, or normal room air it is 21% only. Even if you are giving 70% FiO2, the saturation, that is FPaO2, which is corresponding to the saturation, which is 56%, which is quite low, means the patient is still hypoxic. So you have to increase the FiO2 in the further values. That is the first initial thing you can do from this ABG. Then you look at the systemic step of the ABG, that I told you, the 6-step approach. The first step is you look at the pH. What is the pH? 7.24. So it is less than 7.4, means it is acidosis. Then you look at the PCO2. PCO2 is 60% here. PCO2 60% means it is increased. So the PCO2 increase is the cause of acidosis. That means it is a respiratory acidosis. Okay, so that is not the end. You will get the patient, this is the respiratory acidosis. Then you look at the, you have to find out this is an acute or chronic, right? So for acute, you have to diagnose this acute and chronic. You have to apply in the formula, which is 0.008 into the change in carbon dioxide divided by 10, right? So you applied it at the applied the law. The third step, 0.08 into 40 minus 60 minus 40. 60 is the PCO2 here. So it comes around 0.6, 0.16. So the normal is 7.4. So you minus it from that, you will get 7.24. So that is the expected pH if this is an acute event, acute respiratory acidosis. You look at this, it is 7.24. So that means it is an acute respiratory acidosis. So consider if PCO2 pH is 7.34, means it is chronic, probably because of the chronic, because the pH is not compensated that much. So coming to another case, a 30-year-old with severe diarrhea, diminished urine output, lethargy, and sodium is 135 and chloride is 115, FO2 of 24%. So you look at the clinical scenario again. Somebody is having severe dehydration, maybe, right? So you will not expect a respiratory problem for this baby. So you will be expecting a metabolic abnormality for this baby. So even if that, you will look at the FiO2 and oxygenation. So FiO2 is 24%, PO2 is 87. That is okay, right? So it is, we are not that much concerned about the oxygenation status. Then you coming to the step again, which is a pH of 7.10. What is the first step? Means it is acidosis or alkalosis? It is acidosis. Then the next step is look at the PCO2. You look at the PCO2. PCO2 is low or high. It means it is more than 40 or less than 40. It is less than 40. Less than 40 means that acidosis is not due to the respiratory cause. So it is due to the metabolic cause. So it is a metabolic acidosis. So metabolic acidosis, if you get a metabolic acidosis, you should be not that happy, because you have to have a lot of steps following it. So what are the steps? Next step is you have to find out what could be the cause of the metabolic acidosis. Is it high anion gap metabolic acidosis or low anion gap metabolic acidosis? For that you have to calculate the anion gap, right? So anion gap for this patient is nearly 12. So it is a metabolic acidosis. Anion gap is 12, means normal. So it is a normal anion gap metabolic acidosis, right? So that means this baby is losing bicarbonate. That is the cause of metabolic acidosis. Where from this baby losing, it is due to the diarrhea or vomiting, whatever it is. So it is direct loss of bicarbonate which is causing the metabolic acidosis. Coming to another case, pH of 7.52, PCO2 of 26, PO2 of 112 and bicarbonate 22, base excess of +2 and saturation 92%. SaO2 is 90%. So FiO2 is 33%. A baby girl with lethargy and irritability, right? So this may be drowsy, this may be irritable, and that is maybe because of a metabolic abnormality, right? So you look at the FiO2 again. FiO2 is not that much high. It is maybe through the nasal bronchs they are giving the oxygen. And the PO2 is 112, which is almost okay, right? So we are 112, but she is having 112 and FiO2 is 33%. And this maybe can have a respiratory or metabolic cause, but clinically looks like it's more, both is possible. So you look at the pH. pH is 7.52 here. So it is an alkalosis. So you look at the PCO2. PCO2 is low here. So PCO2 low means it is due to the respiratory cause. So this baby may be breathing fastly because of some lethargy, because of the irritability maybe. She is crying maybe, or whatever it is. She is breathing very fast, so that's why it is the alkalosis, respiratory alkalosis. So again, if you are getting a respiratory alkalosis, you have to find out it's an acute or chronic. So how you calculate the acute or chronic? You look at the pH and you calculate the 0.008 into the change in carbon dioxide. So here it is 0.11 change is acceptable. So it is 7.51. That is a pH according to the prediction by the formula. So it is same. So it is again an acute. So if it is 7.4, 7.45 or 7.48, that can be a chronic component should be there. So coming to another case, pH of 7.14, PCO2 of 70%, PO2 66, FeO2 of 70, bicarbonate is 26, and before that you have to actually go through the clinical scenario again. A case of near fatal asthma on ventilator. Frequency means it is the rate. It is 15, tidal volume 50, PF of 3 and IE ratio 1.1. It's a quite wrong setting for this patient, but you have to assess the ABG. Then you have to change the ventilator settings. So first you check at the pH. pH is 7.14, which is acidosis. So if the acidosis is due to respiratory or metabolic, that you have to find out. So you have to look at the PCO2. PCO2 is 70 here. So that is maybe due to the carbon dioxide. So it is respiratory acidosis definitely. And look at the bicarbonate also. If a bicarbonate is low, also there is additional metabolic acidosis is possible. So bicarbonate is increased here. So it is there is no metabolic acidosis. So there is a respiratory acidosis. Then the next step is PO2 is low and FeO2 is high, means there will definitely respiratory problem is there. That's why the patient is ventilator. So how you calculate if it is acute and chronic? Again you apply in the formula. It is 0.24. That is the value you are getting. So 1.4 minus 0.24, that is 7.14. That is the respiratory. That is the pH you are anticipating for this patient. So this patient is having an acute respiratory acidosis, right? And for this patient, the right treatment will be you reduce the respiratory rate, because a patient having a bronchial asthma or COPD, the problem is at the expiratory end, right? So you have to increase, you have to give more time for expiration. So how in normal patients, if somebody is in respiratory acidosis, PCO2 is quite high, that is maybe because of the respiratory depression, then the scenario will be different. Then you have to increase the respiratory rate to increase the minute ventilation to cause the carbon dioxide washout. But in this scenario, the problem is patient is having bronchial asthma, so the expiratory portion is affected. So you have to promote the carbon dioxide washout by decreasing the respiratory rate, and you have to increase the respiratory time also for giving a complete exhalation time. So that then you reassess the ABG after 1 hour, then you will get a good value. So in another case, a 50-year-old gentleman with abdomen pain, increased urine output, lethargy, sodium 135, chloride 110, and blood sugar is capillary blood sugar is 600 milligram per deciliter. You look at the clinical scenario. This patient is having abdomen pain, increased urine output. So something related to the metabolic cause, right? So something related, sugar is high also. So you have to have some DDs in your mind. So how you have to confirm it by doing an ABG, right? So you look at the PO2 is 87 with the FeO2 of 27%, which is quite acceptable. Then you look at the pH. pH is 7.1, which is acidosis or alkalosis, which is acidosis definitely. Then you look at the PCO2. PCO2 high means it is respiratory, low means it is metabolic. Here it is less than 40, so it is metabolic acidosis only. So this patient is having a metabolic acidosis. The next step is you have to calculate what kind of metabolic acidosis it is, high anion gap metabolic acidosis or normal anion gap. How you calculate? You calculate the anion gap. So the anion gap is for this patient is nearly 22, means it is above 12, means it is high anion gap metabolic acidosis. High anion gap metabolic acidosis. So you have to have the DDs, mud piles in your mind. So mud piles, what is the condition suitable for this patient? This patient, K means mud piles, right? So in that D means DKA. So this patient DKA is possible. So that is one of our DD. So this is how you interpret the ECG. First thing you have to initially you look at the clinical condition of the patient, and you should have a DDs in your mind. In emergency department, we do ABG as an adjuvant to our primary survey to reach the initial initial differential diagnosis or initial intervention. We use ABG as an adjuvant to the primary survey. So if you are getting that, you get a clinical condition, then you do an ABG, you apply that clinical scenario while interpreting your ABG. Then you get the proper differential diagnosis or the treatment modality to improve the patient condition. So for you reviewing the initial steps of ABG, the first step 6-step approach. First step should be look at the pH. If it is low means it is acidosis, then you will get the PCO2. If it is high means it is respiratory, it is low means it is metabolic acidosis. Metabolic. So coming with the opposite for alkalosis also. If the patient is having acidosis or metabolic acidosis, next step is you calculate the anion gap. You calculate the anion gap. Ideally, after calculating the anion gap, you have to, if it is a high anion gap metabolic acidosis, you have to look at the DDs again, and you have to find out any additional cause of metabolic acidosis should be there. For that, you have to calculate the delta anion gap or delta bicarbonate or corrected bicarbonate. Two methods are there. So after calculating that, you will get an idea that if there is an additional additional component is there or not. Okay, then you have to treat accordingly. And finally, you have to find out the compensation also. Compensation by applying that in the formula, and you look at the other parameters. If somebody is having a metabolic acidosis, you apply that in the formula and look at the PCO2, how much PCO2 they are having. If it is elevated or decreased means there is an additional, some abnormality is also there from, if it is elevated or decreased from our anticipated value by applying it in our formula. This is how you approach an ABG. This is a simple method approach of ABG. There is advanced ABG interpretation is also there. So thank you so much.